Mark and Madison, I'd like to invite you to begin by presenting your project findings for the Barnabas Center. Thank you.
Thank you, Dr. Patterson. My name is Madison Reasonover, and I'm currently a second-year master's student in the Psychological Sciences program at UNF.
And my name is Mark Zamani. I'm a second-year PhD student in biostatistics at Florida State.
We also worked with another intern, Payal Agarwal, but she will be presenting on another project this evening. For this project, we partnered with the Barnabas Center in Nassau County to address health service impacts on emergency department utilization. The wicked problem for this project is centered on emergency department or ED utilization. According to the HCUP study in 2017, there were approximately 145 million ED visits nationwide, which resulted in a total aggregate visit cost of $76.3 billion. Additionally, emergency departments from the southern region of the US received approximately 58 million ED visits, which resulted in $27.5 billion in ED spending. Part of the cost for ED utilization is because some individuals, like families who are income constrained or uninsured, rely on the ED as their main form of healthcare service. Thus, a portion of these ED visits could provide better service and quality care at a primary care physician's office where patients can get the attention and follow-up they need for their specific health issue. Now let's focus on Nassau County and the residents' access to healthcare. In 2017, Nassau County was identified as a health professional shortage area due to the lack of primary care services. Looking at this map, you can see not only the disparity in population density between East and West Nassau County, but you can also see the disparity in access to healthcare. A majority of the healthcare facilities, like doctors' offices and walk-in clinics, which are represented by the yellow dots in this map, are concentrated heavily on the east side of Nassau, which further burdens the access to healthcare of these residents. Additionally, Nassau County has significantly fewer licensed physicians per 100,000 residents compared to Florida, as you can see according to the graph below. When looking at Nassau County residents' access to healthcare, you also need to consider the poverty rates of the area as well. Nassau County's population rates below the poverty level, households receiving cash public assistance, and ALICE, or Asset Limited Income Constrained Employed households, are slightly better than that of Florida. However, the unemployment rate in Nassau County has been increasing in past years and is currently almost double that of Florida, sitting at 5.9%. Additionally, 45% of this population of unemployed individuals are also uninsured. So these individuals may represent those who are relying on the emergency departments as their primary source of healthcare due to their severe limited access.
Barnabas services are targeted towards the vulnerable populations in Nassau County, in particular those who are uninsured and live below the federal poverty line. The Barnabas Center's main focus is on social determinants of health, which will help address emergency department utilization. Barnabas provides holistic health services in their community, and this includes primary health care, crisis and therapy services, food assistance, retail store funding, and dental care. Through their partnership with Baptist Health, high-quality medical services through their emergency department are available for those Barnabas patients that would otherwise not have these resources available. We have 4 main project goals. The first is to identify high utilizers of the emergency department. This is categorized as more than 4 emergency department visits in a calendar year. The second would be to determine a % reduction in emergency department visits for established Barnabas patients. The third would be to compare emergency department visit rates between Barnabas and non-Barnabas patients. And our fourth goal is to recommend improvements to health service utilization. In order to address these project goals, we received 3 main data files. The first is Baptist Emergency Department records collected from 2014 to 2020. These visits were a mixture of both Barnabas and non-Barnabas patients with similar demographics. International Classification of Diseases, or ICD codes, were provided post-diagnosis, which are treatment and medical procedural codes that categorize presenting illnesses. And we had around 12,000 rows for this file. 2 Barnabas files were also provided, the first being all clinic visits from 2014 to 2020, which provided demographic information, the encounter type, so whether or not the patient checked out or no-showed, and the facility location are also given in this file, and had around 25,000 rows. The third is the new patient visits file in that same time frame from 2014 to 2020. This provides clinic visit dates, as well as the date the patient first became established as a Barnabas patient.
Here you can see that Nassau County sits directly north of Duval County in the northeast region of Florida. There are 4 major cities in Nassau, as well as their only hospital, the Nassau Baptist Medical Center, located on the eastern side of the region. You also see 5 other Baptist hospitals located throughout Duval and Clay County, in which we receive patient ED data for. Interestingly, there was a small number of Nassau County residents who visited Baptist ED facilities throughout Duval and Clay County. You can also see that Barnabas operates a dental clinic out of Hilliard and a satellite clinic out of Callahan in an attempt to help service the west side of Nassau. However, Barnabas's main center, the Weaver Center, is located on the east side of Nassau in the Fernandina Beach area. Lastly, you can see the density of Nassau County residents who are utilizing these Barnabas services. This is a similar pattern to the population density of Nassau County as well. However, it was surprising to us that there are individuals traveling from Clay and Duval County up to Nassau County to use Barnabas services as well. Now let's find out a little bit more about these Barnabas patients. Barnabas patients represent 2,605 unique patient IDs. The average age of these patients was 49 years old and 59% identified as female. Additionally, 63% pay the Barnabas medical fee rate of $10. Of the patients that utilized the ED, there was 1,737 unique patient IDs, with an average age of 51 years old. Between these 2 sets of data, we have an overlap between Barnabas patients who are also utilizing the emergency departments. This subsection represents 1,256 Barnabas patients with an average age of 50 years old. In order to evaluate the monetary benefit the Barnabas Center has on the ED system, our initial goal was to create a differentiated cost based on ICD codes. However, we met with Dr. Aaron Spalding from Mayo Clinic, who advised us that estimating costs based on ICD codes would not be a fruitful endeavor. Due to this and the fact that there is no access to actual cost data, we decided to modify this goal and transition to calculate an undifferentiated cost. This undifferentiated cost is based on the top 4 ED diagnoses from Nassau County between 2016 and 2019. Within this time frame, there were 4 common ICD codes, including acute upper respiratory, chest pain, and urinary tract infection. These costs only included the average cost of treatment and did not include any additional costs like further treatment, resources, or inpatient care. We averaged the cost across years, factoring in a 3% interest rate yearly to create cost in 2019 dollars. The resulting undifferentiated average ED visit cost was $5,072. Now, applying this undifferentiated visit cost, let's imagine that Barnabas did not exist and individuals who are uninsured or are income constrained would be using the ED as their primary healthcare provider. We estimated that half of all Barnabas office visits would instead result in an emergency department visit and applied the undifferentiated visit cost to this estimate. As you can see, Barnabas patients would be spending millions of dollars yearly in the ED system. These total savings from 2014 to 2020 would result in an additional $45.6 million in ED spending. However, beyond the numbers, Barnabas provides additional support, higher quality of care, and follow-up protocols, which focuses on a holistic social determinants of health approach that simply is just not possible when getting treatment at the emergency department facilities. Shifting to our first goal, we identified high utilizers of the emergency department. Once again, a patient is considered a high utilizer if they visit the ED more than 4 times in a given calendar year. We identified 356 patients who met this classification. The average age of these patients was 50 years old, which is consistent with the overall sample. While some of these high utilizers are visiting between 6 to 10 times in a given year, others on the more extreme end are visiting 30 to 40 times in a single year. Specifically looking at these patients' visits over 4 times in a year, could you please click Dr. Umapathy? Thank you. You can see that these patients are spending millions of dollars yearly in Northeast Florida Baptist emergency departments. These extra visits account for a total of $10.5 million, again, based on our undifferentiated average cost. While the ED often makes referrals to attendants of Barnabas, these high utilizers would likely benefit from the ongoing care and follow-ups that would best be done in a primary care center like the Barnabas Center. Thank you. Apart from costs, we also examine the timing of these ED visits for high utilizers. I'd like to take the time to thank Jay Lewis from TIAA Bank for all the advice regarding our visuals throughout the presentation. These high utilizers, as you can see, based on the heat map, are going between 10 a.m. and 5 p.m. This is consistent with prior literature that says individuals tend to frequent the ED between 11 a.m. and 7 p.m. Additionally, a significant amount of weekend visits are during non-Barnabas operation hours. And when you exclude these visits during Barnabas operation hours, you can see that there's a potential for the Barnabas Center to open midday on the weekend to help service these high utilizers and keep them out of the emergency department. Lastly, the least common hours for visiting the emergency department were very early in the morning or very late at night. Comparing Barnabas and non-Barnabas patients, you can see the relative concentrations for ED visit timings are generally the same, as we do have a smaller representation of non-Barnabas patients. However, you can see that there are more Barnabas patients going to the emergency department early in the morning. This is suggesting that perhaps they aren't feeling well, they try and sleep it off overnight, wake up in the morning and nothing is better, and their first instinct is to go straight to the emergency department. Here, there is also potential for the Barnabas Center to open slightly earlier in the mornings on weekdays to help service these general ED users.
Our second project goal is to determine a % reduction in emergency department visits for established Barnabas patients. And we also tie in our third project goal, which is to compare emergency department visit rates between Barnabas and non-Barnabas patients. As we try to pursue these goals, we have to deal with the potential for selection bias. Selection bias occurs when there are systematic differences between two populations. In the context of Barnabas, this is based on the patient's choice, as some patients choose to go over to Barnabas and some patients choose to go elsewhere, producing a selection bias in the pre-existing differences between the two populations. Take the two colors to stand for patients with different presenting illnesses. Due to underlying differences between the two populations, if we were to compare the groups one by one, this would lead to unequal characteristics between the groups and in turn lead to incorrect analysis. Our goal is to work against this selection bias. To address this, we looked into a number of different factors that might show initial differences between the two groups, and one of these factors is age. Barnabas patients as a whole had a younger population relative to non-Barnabas patients, and non-Barnabas patients had a larger proportion of patients over 65 years old. Older patients tend to have more health concerns, therefore we need to control for this to prevent selection bias. Another factor that could be contributing to the initial differences between Barnabas and non-Barnabas patients is the severity of their presenting conditions. From our data, we found ICD codes tend to be complicated and cumbersome to work with. But based on the recommendation of Dr. Hamadi, a professor of health sciences at University of North Florida, we converted these ICD codes into a comorbidity index known as Alexhauser scores. Comorbidities are the prevalence of multiple chronic illnesses. And this is of great interest to the clinician because patients with comorbidities tend to have longer and more frequent stays in the emergency department. Alexhauser scores track several of the most common comorbidities in emergency department patients and give a score of 1 to 6, depending on the severity of illness and if more than 2 comorbidities are present. If we subset by high utilizers, chronic obstructive pulmonary disease, or COPD, alcohol, diabetes, and depression were the most common comorbidities in Barnabas patients. Non-Barnabas patients tended to have a larger proportion of visits due to depression, neurological disorders, and arrhythmia compared to Barnabas patients. Due to the range of severity between the patient's ICD codes, this comorbidity index will be used to prevent comparing Barnabas and non-Barnabas patients with conditions at different severity, and is another aspect in correcting for the present selection bias. Based on these factors, we decided to match Barnabas and non-Barnabas patients based on 3 main criteria: their age, the year of their first emergency department visit, and their comorbidity scores. This ensures to the best of our ability that the analysis is performed on groups with the most similar characteristics from the available data. Our first point of analysis was to model this matching data in order to predict the chance of being a high utilizer. Logistical regression was run to give the odds of showing high utilization based on our matching criteria covariates. While we did see a significant difference in the chance of being a high utilizer after their first year of emergency department visits, an overall decrease in odds of 35%, our model fit for variability was low. The regression gave an R-squared of 0.05, meaning that only around 5% of the variation in the response, being a high utilizer, could be explained by our model. We believe a potential reason for this is the relatively small number of variables, and further research is needed on these patient characteristics to obtain more informative covariates for the model. Carrying on with the matching, we had 296 match pairs based on our covariates of interest, and it was found that the probability of being a high utilizer for both non-Barnabas and Barnabas groups was around 9%. We plan to use these match groups to further compare emergency department changes in emergency department visits over time. After matching, we found that both Barnabas and non-Barnabas patients showed a 1-year reduction in emergency department visits. In addition, there was around a 10% reduction in emergency department visits when Barnabas clinic new patient visits were present. This means that a patient who had emergency department visits the year they became a Barnabas patient saw around a 10% reduction 1 year after in their amount of ED visits. This may be a lower bound estimate, meaning that with additional information, we believe this number could be higher. If we were to look further in time, we could see the improvement in the trend of emergency department visits after becoming a new Barnabas patient. And as previously indicated, there's additional research needed on how to better obtain matching criteria for comparison. Our final project goal is for recommendations to improvements in health service utilization. As Madison mentioned previously, we saw the majority of Barnabas patients that visit the emergency department during non-Barnabas hours tended to visit in the 2 to 3 hours before the center opened. That is why we're recommending modifying Barnabas service hours to open slightly earlier on the weekdays in order to potentially service these patients who would otherwise visit the ER. Related to that, opening midday on the weekends would also potentially help service more Barnabas patients, in particular those who are high utilizers, since these patients tended to be the most frequent visitors of the emergency department in that time frame. Our third and fourth recommendation would be potential modifications to both the intake form and referral process for patients at Barnabas. Screening for comorbidities may allow for more efficient referrals to services in order to treat any specific condition. All these recommendations combine to the ultimate goal for this section, which is an improvement to health service utilization for Barnabas Center and Baptist Health. I thank you all for attending and listening to our talk.